everyone, myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So today we are back with the AAA series where we'll be discussing the important topics which are pertaining to the MRCPI written exam. So today we'll be discussing about an important topic which is on stress urinary incontinence. Okay. So always remember that success is focusing the full power of all you are and what you have a burning desire to achieve. So always believe in yourself and keep preparing and always keep practicing the questions and success will be yours. Yeah. So coming to stress urinary incontinence. So before going to the stress urinary incontinence, we will go to the different types of incontinence that are there. So first is the stress urinary incontinence where there is, as the name suggests, stress. So it is due to any kind of stress that is put on the abdomen, which causes the raised intra-abdominal pressure, like any cough or sneezing or laughing or jumping, which causes the raised abdominal pressure and which causes involuntary leakage of urine on this intra-abdominal pressure. Because of this intra-abdominal pressure is called as stress urinary incontinence. Whereas urge is where the patient has a sudden urge to pass urine, and before the patient reaches the toilet, there is involuntary leakage of the urine. And in mixed, it is combination of both the stress and urge incontinence, where there are features associated with the urinary leakage on stress, that is coughing, sneezing, laughing, and also the patient has urgency symptoms and before reaching the toilet, they leak. So there can be predominant in mixed incontinence, there can be a predominant stress urinary incontinence or a predominant urge incontinence. In functional incontinence, it is due to any physical disability or an external obstacle which causes untimely urination before the patient reaches the toilet. And in overflow, it is usually due to an overflow bladder which causes a small dribbling of urine. So coming to the stress urinary incontinence, so what happens in a continent bladder, in a continent normal woman? So here usually the pelvic floor muscles that are usually strong in a normal continent woman. So that is needed. That is a strong pelvic floor muscles and also the sphincter, the intrinsic urethral sphincter that should be strong, and also the muscles when the bladder is full. So at the time of urination, the sphincter muscle should contract in case of coughing or sneezing. But so if you can see in the first picture in a normal bladder, so here whenever there is a full bladder, okay, so and when there is an increased abdominal pressure in a normal continent woman, the sphincter muscles, the urethral muscles contract and the urethra is closed, and also there is a pelvic floor muscles which are strong and which helps in contracting this urethral muscle. But what happens in a stress urinary incontinence? So the main pathophysiology is due to an intrinsic urethral deficiency, or which prevents closing of this urethral sphincter, or also if there is a pelvic floor muscle weakness. So it can be due to various conditions. Okay, so we'll come to that. So in stress urinary incontinence, when the bladder is full and when the patient has an increased abdominal pressure, either due to coughing, laughing, or like sneezing, jumping. So here, during the time of coughing, here the sphincter muscles relaxes and the urethra opens instead of closing, and also due to the weak pelvic floor muscles as a cause, the urine leaks out. So here it is due to the weak pelvic floor muscles and the sphincter deficiency which prevents the proper closure of the urethra and which causes the stress urinary incontinence. So what can be the different causes or the risk factors which can cause stress urinary incontinence? So in all these conditions, which we can see, there is the pelvic floor muscles which support the urethra, they are weak. Okay. And also there is a intrinsic sphincter deficiency. So what can be the causes? So that pregnancy and childbirth due to the hormonal changes or during the time of delivery. So it becomes the pelvic floor muscles, and also it damages the nerves that control the bladder. So all these conditions, the menopause, it is due to hypoestrogenism, which can the pelvic floor muscles, which prevent the urine leaking, can provoke the symptoms if the patient is menopausal. Also in aging, the urethra, there is a mostly there is a pelvic floor muscle dysfunction, and the muscles weaken down. Hence, the control of the urine is lost in cases of aging. And in cases like pelvic surgery or sometimes radiotherapy, there can be intrinsic sphincter deficiency, which prevents the closure of the urethra when the bladder is full and the patient puts an increased abdominal pressure. Also, certain conditions which increase abdominal pressure, like constipation or obesity, or chronic conditions, medical conditions like asthma or COPD, which can increase the abdominal pressure, can also worsen the SUI symptoms due to pelvic floor muscle dysfunction, and intrinsic sphincter deficiency. So what can be the distinguishing factors between the stress urinary incontinence and urge incontinence is here. In stress incontinence, the incontinence happens with any loss of due to when there is a leak when associated with cough or sneezing or activity. Anything which causes increased abdominal pressure and leakage of urine is SUI. In urge incontinence, there will be history of sudden onset of urge of passing urine, and before the patient reaches the toilet, there is a leakage of urine. So what can be the precipitating factors? It can be cough or obesity or constipation in case of SUI, or any strenuous activity like jumping, which can cause SUI. In urge incontinence, it's a full bladder which causes the sensory triggers, like especially running water, which causes a sudden urge to pass urine. So the urinary frequency is often increased in case of urge incontinence because there is a sudden urge to pass urine. And in the nocturia, that is passing urine in the night frequently, is seen more in urge incontinence. While the volume of urine loss in case of stress urinary incontinence, it is in small amounts, whereas in urge incontinence, the volume voided is in large amounts. So how to deal with the patient with the if the patient comes with a case of incontinence? So main is always serially we have to take a proper history from the patient. We have to ask the age and her symptoms. Since when is she having the symptoms, and how has the symptoms worsened since before, and has she taken any treatment so far for the symptoms? Asking that is very important. And what are the aggravating and relieving factors that cause the symptoms? Also, how much it is affecting the quality of life? It is very important in case of urogyne history taking. Then have to ask the menopausal status of the woman, because we know that we have seen in the last slide that it is most common in the postmenopausal woman due to weak pelvic floor muscles. Also, we ask about the previous obstetric histories because as we know, the number of normal deliveries, especially the more the deliveries, the more the birth weights of the baby, or any history of instrumental or a vacuum delivery, or any postpartum incontinence may increase the risk of urinary incontinence. So knowing that history is very important. Followed by that, we ask the other medical conditions if they have any, especially asthma, COPD, or any ailments like constipation, which can also increase the risk. And other surgical surgeries, especially any pelvic surgeries, because we know that that can also cause the intrinsic sphincter deficiency. Then we ask about any allergies for the patient before prescribing any treatment as a patient safety point. And we should note the BMI, because we know that the high BMI can also provoke the SUI. Then the blood group, any reservations if they have, also we know, and the VT risk profile, VT risk assessment should be done for the patient. And their psychological status also should be, because the SUI, it is quite a disturbing condition and socially disturbing, we can say, because the urine leaks in suddenly on coughing or laughing, so that may make like the patient socially disturbed. So this needs to be asked in detail. So here, and any previous surgery for incontinence especially also should be asked. So after proper history taking, then we need to examine the patient here. So in case of SUI, here first the full bladder examination is done and the cough test is done to look for, the patient is told to cough to look for and to demonstrate any SUI, stress urinary incontinence. Followed by that, the patient is told to empty the bladder, and then we need to examine the patient. First, we need to do the general examination, take the verbal consent from the patient, wash our hands, stand on the right side of the patient, and make the patient lie down, then cover the patient and only expose the area which you are going to examine. So first we do the general physical examination, followed by the respiratory examination, then the cardiovascular, the per abdominal examination, especially to look for any masses which can cause the raised abdominal pressure. And the local examination, where we look for the menopausal status, how is the estrogenization, because the stress incontinence can even cause some redness or itching of the vulva because of the leakage of urine. And followed by that, a per speculum or a vaginal examination is done. After that, we need to send some investigations in the form of urine analysis to rule out any urinary infections. And also, if the infection is noted, then we need to send the urine culture. And then we need to do some basic blood investigations. And then what are the management options? So if it is the SUI is a diagnosis, like there is leakage of urine on cuff, so we make a presumed diagnosis of stress urinary incontinence, where the management is mainly of the lifestyle measures followed by medical treatment and surgery. So we'll come to that. Or it can be a mixed incontinence, where the management is again lifestyle and medical, bladder training, and also surgical. And there can be overactive bladder without urgency, where the management, that is we call as a detrusor activity, where we give lifestyle measures and also the pelvic floor muscle training and bladder training in case of overactive bladder, and by medications like antimuscarinic agents. There can be sometimes complicated incontinence, which happens in cases of recurrent incontinence, or if it is complicated by hematuria, or if there is patient has undergone irradiation and then had incontinence. So this is called as a complicated incontinence. In this cases, if the patient is referred to the MPT, that is a urogynecologist, and then the patient is treated. So what is the management of a stress urinary incontinence here? So it is usually a no treatment or a non-surgical management or a surgical management. So in non-surgical management, first is always the lifestyle measures. So we like in case of the patient has high BMI, we tell them to lose weight, because the studies have shown that losing at least 8% of the body weight can improve the SUI symptoms in almost 50 to 60% of the cases. So that should be explained to the patient. And any other risk factors like smoking, so which can also increase the abdominal pressure, so they should be referred to stop smoking services. And also, if any cough or any medical conditions which can cause SUI like asthma, or they should need to be treated. Then is the pelvic floor muscle training, which is very important, because we know that the cause for SUI is the weakened pelvic floor muscles. So to strengthen this pelvic floor muscles, we advise them pelvic floor muscle training for 12 weeks, that is 3 months. And they have to do this 8 contractions 3 times a day for almost 12 weeks. So that are called the Kegels exercises, which strengthens the pelvic floor muscles and then supports the urethra. Then other continence specialties which can be given. There is a medical treatment, the duloxetine, which is a selective serotonin and a norepinephrine reuptake inhibitor. So it acts at the level of the urethral sphincter. So it contracts the urethral sphincter, and hence it improves the symptoms of the SUI. But it also comes with the side effects as it is an SSRI. So that should be explained to the patient that sudden withdrawal is not recommended. The medicine should be, the dose should be tapered slowly. And the local estrogen in case of postmenopausal woman is recommended. And as I said, weight loss is recommended. In case of surgical management, so there are bulking agents. So as you can see in this case, so here bulking agents like a collagen or an autologous fat. So that can be through a needle and an endoscope that can be inserted in the urethral muscle. Okay, and then that helps in closure of this urethral sphincter. We can see. Okay, so it was open before, and then because of this bulking agents, it causes closing of this urethral sphincter. Helps in closing the urethral sphincter. So but the thing is here, there are some side effects. As it is successful in almost 60% of the cases, but there are some complications that the bulking agent may migrate to the lymph nodes, or it may cause infection or even abscess. So this should all be explained to the patient, and or it can come out. So this all should be explained to the patient. Then the next is the Burch-Kolpo suspension, as you can see in this picture. So here the thing is that the sutures are passed on both the sides of the urethra. At the urethral level, both the sutures are passed up to, and they are attached, reinforced to the Hooper's ligament, that is the iliopectineal ligament. So here that is the urethra is stabilized in this case. Then is the retropubic the sling procedures. So retropubic means here the sling is passed. It can be an it can be rectus fascia or fascia lata, or it can be an like mesh. So which can be passed through the retropubically. So it comes in a transvaginal or a transobturator sling. So when it is passed in a transvaginal, it is passed through the vagina and passed retropubically, and then the suture, the sling is brought out through the skin near the suprapubically. And in case of transobturator, here again the sling is inserted vaginally and brought out through the obturator foramen, as we can see, and the slings are brought out by the in the groin level, groin skin. So what can be the complications of this, the patients who undergo SUI surgery? So as we know, the surgery is almost successful. Any type of surgery is almost successful in 85% of the cases, meaning that 15% will still have failure and improvement of symptoms. So this should be explained to the patient. And there can be certain complications which can happen, like avoiding difficulty or urinary retention, especially, or a urinary tract infection can happen because of these procedures. There can be post-operative dyspareunia, especially those who have a mesh, and there can be mesh erosion in some cases. There can be aggravation of pelvic organ prolapse, or there can be device failure or migration, as I said, in case of mesh, or collagen in case of bulking agents. They can migrate to the other areas like lymph nodes, and or there can be persistent or recurrent urinary incontinence in such cases. So that was all, guys, about stress urinary incontinence. Thank you for attending. Goodbye.